Hi, sir. We are on live.
Yes.
Yeah. So, sir, with your permission, we are starting today's session. Good evening to everyone present here with us today. This is Shreyan from IGCP. I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared our keynote speaker doctor for today's session. With much pleasure and honor, I would like to welcome a very renowned professor, Dr. Bharat J. Parmar. Sir is a professor and head of pediatric department, Zydus Medical College and Hospital, Dahod, Gujarat. Sir is also national trainer for recent protocol management of dengue. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is megaloblastic anemia in children. Before moving on to today's session, let us have a brief look on what the topic says. Megaloblastic anemia in children is a hematology disorder characterized by enlarged and abnormal red blood cell, often stemming from vitamin B12 and folate deficiency. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. Over to you, sir.
Okay. Thank you for your kind words. Good evening to all. I am very thankful to IGCP group giving opportunity to me, sharing my updates and thoughts about this today's topic, that's the megaloblastic anemia. Megaloblastic anemia is a hematological term to describe anemia with the presence characteristic in the peripheral smear. There is large RBC with finally dispersed nuclear chromatin and disproportionate nucleus and the cytoplasm. Megaloblastic anemia is a multi-system disorders which can easily be diagnosed with a high index of suspicion. A complete blood count and the review of blood and bone marrow film reflect the typical pathognomic cytologic appearance of megaloblastic anemia. It is commonly caused by deficiency of two essential cofactors for the synthesis of nucleic acid. There is a vitamin B12 and folic acid. The rare cause include thiamine deficiency or thiamine dependency state and inborn error of nucleic acid metabolism. There is orotic aciduria and a Lex-Nyhan syndrome. Peripheral smear in a megaloblastic anemia, irrespective of etiology, characteristically shows there is a macrocytic RBC with immature erythroid cells and the presence of megaloblast and hypersegmented polymorph with neutropenia and thrombocytopenia of variable severity. Assessment of metabolites like serum homocysteine and methylmalonic acid in serum and urine is considered to the most sensitive and the specific, whereas serum cobalamin and the folate level are of a limited value. It is highly amenable therapy once the primary cause is established. The appropriate replacement therapy of deficient nutrient, cobalamin or folate, or both, easily correct anemia. Megaloblastic anemia is one of the important cause of anemia in children, and in distinct type of anemia characterized by macrocytic RBC and typical morphological characteristic precursor known as megaloblastosis. Megaloblastosis describes the diverse group of disorders with common morphology. There is a large cells with arrest in a nuclear maturation. Nuclear maturation is immature relative to the cytoplasmic maturity, which is due to defective synthesis and a lesser extent due to RNA and protein synthesis. This condition has a protein manifestation in childhood, sometimes mimicking hematological malignancy like leukemia. In developing countries, most of the cases of megaloblastic anemia result from nutritional deficiency of micronutrient. There is folic acid and vitamin B12. The folic acid and cobalamin are a B group vitamins that play an essential role in many cellular processes. Due to deficiency of one or both of these vitamins, megaloblastosis occur due to asynchronicity between nucleus and cytoplasm due to inhibition of DNA synthesis. Other than megaloblastic anemia, the deficiency of these hematopoietic micronutrient in children and incremented to cause neurodevelopmental dysfunction, involuntary movements, and failure to thrive. The diagnosing megaloblastic anemia assumes great clinical importance since it responds exceedingly well to the treatment. The varied presentation of megaloblastic anemia with pancytopenia and vasculotoxic effect of there is a hyperhomocythemia resulting from folate and the vitamin B12 deficiency, and the possible role of their deficiency causing bone loss, leading to osteopenia, osteoporosis, and pathological fractures, has brought vitamin B12 and folate deficiency and megaloblastic anemia back in focus. Megaloblastic anemia, a general term used to describe group of the disorders, and it is important for the synthesis, which leads to abnormal finding in peripheral blood smear. There is a macroovelocytes, and also there is a multicellular in bone marrow sample. There's a megaloblastic, any macrocytes in bone marrow, the megaloblastic hyperplasia. So two important features. One, there is a macroovelocytes in peripheral smear and megaloblastic hyperplasia on bone marrow. Megaloblast, the hallmark of this anemia, are formed as a result of asynchronous maturation of nucleus and cytoplasm due to DNA synthesis impairment. Epidemiology of megaloblastic anemia. The frequency of megaloblastic anemia is the highest in the country in which there is a malnutrition rate is high, and that due to there is vitamin supplementation for elderly individual and the pregnant woman is not available, and it lead to maternal malnutrition and megaloblastic anemia. The faulty cooking practice, it results in a loss of folate, which can lead to megaloblastic anemia. And the prevalence of anemia, as per National Family Health Survey F4, there is a NFHS 4 data has been as high as 60%. However, the data does not indicate the proportion of megaloblastic anemia among these anemic subjects. Megaloblastic anemia, there is a metabolism of folate and cobalamin. The chemical name of folic acid, there is teryl glutamic acid. So the folate are essential mainly a biochemical reaction like synthesis of purine, thiamine, and deoxynucleic acid. There is a DNA synthesis. And adenocyclocobalamin and methylcobalamin are biologically active form of vitamin B12. Adenosine is a tissue form of vitamin B12, while the methylcobalamin, it circulates in the blood. And hydroxycobalamin in the precursor of about two form. Nutritional aspect of vitamin B and folate. Vitamin B12 in the vegetables, it is poor and it is rich in meat. And the effect of cooking, there is a vitamin B loss is 10 to 30%. And this daily allowance of vitamin B12, it is 0.2 to 1 microgram. And the site of absorption of vitamin B12 is a ileum, and body store of vitamin B12, it is 2 to 5 milligrams. While the folate, it is rich in vegetables, and in meat, it is a moderate amount. And on cooking, there is a loss of folate is 60 to 90%. And the daily allowance of folate, it is 25 to 200 microgram. And site of absorption of folate, it is duodenum and jejunum. And the body store of folate, it is 5 to 20 milligram. Etiology and pathogenesis of megaloblastic anemia. The principal cause of megaloblastic anemia in a clinical practice are a cobalamin and folate deficiency indirectly due to drug-induced suppression of DNA synthesis and inborn error of metabolism. The major cause of cobalamin deficiency, there is a dietary. The strictly vegetarian who are avoiding meat, eggs, and the dairy product, they are prone to develop megaloblastic anemia. And the problem with cobalamin absorption include atrophic gastritis, achlorhydria, and also autoimmune destruction of gastric parietal cells, leading to failure of intrinsic factor production. This later condition, it is called pernicious anemia. Rarely the inborn error of metabolism can lead to vitamin B12 deficiency. Major cause of folate deficiency, the main cause of loss of folate from the food is a poor food preparation due to dilution of the food, and there is excessive heating and inactivation of folate, and it leads to megaloblastic anemia. The folate deficiency occurs in a situation where there is an increased physiological demand of the folate in chronic hemolytic state like sickle cell anemia, hereditary spherocytosis, elliptocytosis, and during pregnancy, there is an increased folic acid demand and it leads to megaloblastic anemia. The infection like human immunodeficiency virus infection or myelodysplastic disorders cause megaloblastic anemia due to direct effect of DNA in a hematopoietic and other rapidly dividing cells. Clinical features of megaloblastic anemia. The children with megaloblastic anemia are commonly malnourished, and clinical features include pallor, anorexia, irritability, and easy fatigability like other anemia. And clinical features peculiar to the megaloblastic anemia include hyperpigmentation of knuckles and the phalanges, hepatosplenomegaly, 30 to 40% case, and sometimes icterus, and petechial and other hemorrhagic manifestation like intracranial hemorrhage and the gut bleeding presenting as a hematological emergency has also been reported. And the presence of bleeding with severe anemia make them clinically indistinguishable from aplastic anemia. Children with megaloblastic anemia may also mimic acute leukemia due to presence of hepatosplenomegaly. Fever is one of the clinical manifestation, but often unrecognized and was noticed in 65% case in one study from India. Neurological symptoms in megaloblastic anemia, there's a tremor, paresthesia, hypotonia, seizures, delayed development, and developmental regression in association with severe anemia and can sometimes presenting manifestation. And these cases may show diffuse cortical atrophy on MRI brain and impairment of cognitive function and persistence of neurological consequence even after treatment are a major area of concern. Laboratory features. The laboratory features of megaloblastic anemia comprise changes in the peripheral blood and bone marrow and serum concentration of methylmalonic acid and homocysteine and serum level of vitamin B12 and folate. The megaloblastic anemia, there's a macrocytic anemia in the most of the cases result from the deficiency of B12 and folate deficiency. This means peripheral smear and the red cell indices will show macrocytes and the bone marrow reveal megaloblast. And normocytic macrocytic anemia occur in association with large number of the various disorders. So macrocytosis is commonly seen in hemolytic anemia and post-hemorrhagic anemia. So macrocytosis is occasionally also in leukemia, alcoholism, liver disorders, aplastic anemia, sideroblastic anemia, myelodysplastic syndrome, anemia due to marrow infiltration, cytotoxic drug injury, hypothyroidism, chronic obstructive lung disease, scurvy. Here, bone marrow examination will not show megaloblast. Complete blood count and peripheral smear in megaloblastic anemia. All blood cells are affected and erythrocytes vary markedly in size and shape, and some are large and oval. There's a macroovelocytes. The morphological changes are directly proportional to the severity of anemia. And circulating megaloblast, there is a nucleated red cells that fail to mature appropriately are visible in circulation, and hematocrit is less than 20%. Anemia, typically macrocytic with mean corpuscular volume 100 to 110 FL or more, and reticulocytopenia, the reticulocyte count is less than 1%, is a frequent finding. And this occurs because of incoordinate impairment of erythropoiesis circulating in intramedullary destruction of megaloblast, and resultant there is a torticulocytopenia. There is a progressive reduction in white blood cell count, but it is rarely fall below 2000 cells per microliters. Neutrophil hypersegmentation, there is a more than 5 lobes. At least 5% of the neutrophil or even single this WBC showing 6 and more lobes is a cardinal feature of megaloblastic anemia. There is a hypersegmentation of WBC, and it is noteworthy that the nutritional megaloblastic anemia, there is hypersegmented neutrophil with megaloblastosis. The complete blood count often reveal anemia, leukopenia, thrombocytopenia, and pancytopenia is also common finding in megaloblastic anemia. Also, there is reticulocytopenia in also megaloblastic anemia. So rarely, microangiopathic hemolytic anemia like picture with Burr cell and fragmented RBC seen in severe vitamin B12 deficiency. And this is referred as pseudo thrombotic microangiopathy. Serum vitamin B12 and folate. These tests have limited value because of their low sensitivity and specificity. There is a wide variation of cutoff value, especially to diagnose vitamin B12 deficiency. The previous study showed that vitamin B12 level were either normal or elevated in antecedent liver disease and intestinal bacterial overgrowth. Although tissue store may be normal and serum folate level can decrease with a few days of dietary restriction. However, cobalamin less than 200 picogram per ml and folate is less than 2 nanogram per ml are consistent with deficiency of this vitamin in the most of the quoted study in literature. Red blood cell folate. Red blood cell folate level is regarded as more reliable source of determining tissue store of folate. Unlike serum folate, which is affected by dietary intake, RBC folate level remain constant throughout the span of red blood cell. Measuring RBC folate level have also fraught with unreliability. Investigation for inborn error of metabolism. When other common causes are excluded, urine for orotic acid and tandem mass spectro, there is a mass spectrometry for a metabolic disorder should be done to rule out orotic aciduria and lax bone marrow examination. The aspirated marrow is often hypercellular with a striking imbalance in nuclear cytoplasmic maturation, referred as nuclear cytoplasmic asynchrony. In view of erythroid hyperplasia, the ratio of myeloid and erythroid ratio, it is 1:1 and even lower. And megaloblastic anemia, we usually show hypersegmented neutrophil in the blood and giant metamyelocytes and the bands in the marrow. It is noteworthy that megaloblastic anemia may be misdiagnosed as acute leukemia when megaloblastic anemia is very severe. In this case, the typical megaloblast are obviously absent. Rather, most of the cell available are bizarre and megaloblastic pronormoblasts that dominate the marrow because of lack of maturation of erythroid series and hence raising possibility of erythroleukemia. Serum concentration of methyl malonic acid and homocysteine in megaloblastic anemia. Overall, measuring serum methyl malonic acid and homocysteine level are established way of distributive deficiency of folate deficiency and vitamin B12 cobalamin deficiency. In folate deficiency, there is a marked elevation of homocysteine level, while serum level of methyl malonic acid elevated, whereas in cobalamin deficiency, there is a marked elevation of both metabolites. In folate deficiency, there is a marked elevation of homocysteine level, while serum methyl malonic acid elevated, whereas in cobalamin deficiency, there is a marked elevation of both metabolites. LDH level is elevated, and the marker of ineffective erythropoiesis is often seen in megaloblastic anemia due to both vitamin B12 and folate deficiency. Urine, there is excessive elevated methyl malonic acid in urine. Normally, it is 0.30 to 3.5 milligram per 24 hour is reliable, and it is a sensitive index for vitamin B12 deficiency. Various causes of megaloblastic anemia. First, due to cobalamin deficiency, due to dietary deficiency, deficiency of intrinsic factor, there is a pernicious anemia. In gastrectomy, there is a megaloblastic anemia, malabsorption and megaloblastic anemia, ileal resection, megaloblastic anemia, in hypothyroidism, megaloblastic anemia, and methyl malonic anemia due to defect in early steps of vitamin B12 processing. So these are the common causes of there is cobalamin deficiency and megaloblastic anemia. Vitamin B12 refer to a group of cobalt-containing vitamin compound called cobalamin, and these are the cobalamin formed using activated charcoal hydroxocobalamin produced by the bacteria, and the two naturally occurring cofactor methyl malonic CoA mutase, there's a MUT, and methyl cobalamin, and 5-methyl tetrahydrofolate, there is a homocysteine methyl transferase, there is a MTR. So synthesis, vitamin B12 is mainly synthesized by bacteria. There is a Acetobacterium, Aerobacter, Flavobacterium, Proteus, and Pseudomonas. And industrial production is through the fermentation of selected microorganisms like Streptomyces griseus, Pseudomonas tuficans, Propheni, Bacterium, and Sharamani. These bacteria, they synthesize vitamin B12. The function of vitamin B12, it is normally involved in the metabolism of every cell of the body, and it affects the DNA synthesis and the regulation, and also fatty acid synthesis and energy production. Part of the function of vitamin B12 are shared by adequate dose of folic acid, and vitamin B12 is used. They regenerate folate in the body. So most of the vitamin B12 deficiency are actually folate deficiency symptoms. There is a pernicious anemia and the megaloblastosis are due to poor synthesis of DNA, whereas inadequate folic acid it for the thiamine production. Vitamin B12 deficiency, the most common manifestation of megaloblastic anemia, 85% of megaloblastic anemia, vitamin B12 deficiency was documented, and the nutritional deficiency of folate, vitamin B12 and both are commonly seen in vegetarian than non-vegetarians. H. pylori infection also they result into vitamin B12 malabsorption and megaloblastic anemia. And the source of this vitamin B12, there is a liver, egg, and the meat. And the recommended daily allowance in a normal children, vitamin B12, it is 2 microgram per day, and during pregnancy, 2.6 microgram per day. Vitamin B12 deficiency manifests as a megaloblastic anemia, and there is a neurological abnormality. There is a subacute combined degeneration of spinal cord in adolescent and adult. Vitamin B12 deficiency. The daily requirement of vitamin B12 is very low. It is 1.5 milligram, and which is easily fulfilled by the dietary sources, and the vitamin B12 precursor present in almost all food. So vitamin B12 absorption required it hydrolysis by the gastric acid, and the combination of this specific, this intrinsic factor of Castle, IFC, present in stomach, and it is mainly absorbed in the distal ileum, and there is transplasma bound to form of protein transcobalamin. Clinical manifestation of vitamin B deficiency, it is known as juvenile pernicious anemia, and is a rare autosomal recessive disorders of IFC deficiency. It is a prototype of vitamin B12 deficiency, and this case usually present at 9 to 12 months with a triad of progressive severe anemia, glossitis, red, smooth, and the painful tongue with CNS sign. There is ataxia, paresthesia, and hypo or hyperreflexia in case of pernicious anemia. Vitamin B12 deficiency due to other cause presents similarly except difference in the age of presentation and the severity. The diagnosis is established by megaloblastic peripheral smear, low serum vitamin B12, there is a less than 100 picogram per ml, and urinary excretion of methyl malonic acid, it is more than 3.5 milligram per dl, and skilling test. Skilling test is used to establish presence of vitamin B12 deficiency as well as differentiate between IFC deficiency and malabsorption defect part 2. In the first part, the small amount of radio label 57 cobalt vitamin B12 given orally, followed by flushing dose of 1 milligram parental vitamin B12 after 2 hours, which leads to excretion is more than 10 to 30% of labeled dose in urine, and excretion of less than 2% reliable labeled vitamin B12 indicate its retentions and vitamin B12 deficiency. In second part, the test is repeated with 30 milligram of IFC factor given along with radioactive dose, and correction of test result indicate this intrinsic factor deficiency, while persistent abnormalities suggest malabsorption. The management of vitamin B12, there is an oral vitamin B12 therapy, is unsuccessful in the most of the cases. The cases without neurological signs are treated by lifelong therapy. There is an intramuscular injection of vitamin B12. There is a 1 milligram per month, while those with neurological sign need more intensive therapy for first 2 weeks. There is a vitamin B12 intramuscular 1 milligram per day, followed by monthly injection. Folic acid, there is a vitamin B9. Folic acid and folate are a natural form of vitamin B9 and itself are not biologically active. They are converted to tetrahydrofolate. They are biologically active component. The function of folic acid, folate is essential in infant and in pregnancy, especially during cell division and the growth. RNA synthesis also required folate, and folate decrease risk of cerebrovascular accident and hypertension. The source of folic acid, there is a green leafy vegetable, spinach, egg yolk, dried and fresh beans. There is a fortified cereals, peas, leaflets, liver and liver products, and the fruits. Folate deficiency result in megaloblastic anemia. The deficiency during pregnancy leads to neural tube defect, preterm delivery, fetal growth retardation, there is a IUGR, and increase homocysteine level and spontaneous abortion. The recommended allowance of folic acid in the pregnant woman, it is 600 to 800 microgram per day, and normal adult, the daily allowance, it is 60 to 100 microgram folic acid per day. Folic acid deficiency, it is due to dietary deficiency and the defective food processing due to dilution and excessive eating. Folic acid deficiency also in case of malabsorption, also due to extensive bowel resection. Anticonvulsant and oral contraceptive also result into folic acid deficiency and megaloblastic anemia. and increased physiological demand. There is a chronic hemolytic state. There is a sickle cell anemia. It leads to megaloblastic anemia, megaloblastosis. Folic acid deficiency. Normal folic acid requirement in children 100 milligram per day and supplied as a folate in the most of the food except in goat. If goat milk and camel milk, their deficiency of folic acid result into megaloblastic anemia. It is absorbed throughout the intestine. The folic acid deficiency, rarely dietary, usually seen in cases with poor absorption in malabsorption syndrome. Also, in case of fish tapeworm, there's a deep latent infestation. It results into megaloblastic anemia. An increased requirement in hemolytic anemia, there's a sickle cell anemia, they lead to megaloblastic anemia. An impaired folate metabolism due to drugs, there's a methotrexate, pyrimethamine, and phenytoin. It results into megaloblastic anemia. And a dietary deficiency in the babies fed on a goat and the camel milk or unfortified powder milk. It results into megaloblastic anemia. Clinically, the most of the cases present at 4 to 7 months of the age with progressive developing chronic anemia, failure to thrive, chronic diarrhea, neurological features, there is a tremor and developmental regression, hyperpigmented, there is a over the dorsum of the finger and thigh, and the bleeding in severe case due to thrombocytopenia, and the combination of megaloblastic anemia, neurological signs, and the cutaneous hyperpigmentation, it suggests possibility of infantile tremor syndrome in the children. Diagnosis of megaloblastic anemia due to folic acid deficiency, there is a megaloblastic peripheral smear, there is a low serum folic acid, it is less than 3 nanogram per ml, normal it is 5 to 20 nanogram per ml, and positive FIGLU test, there is excretion of 4-menoglutamic acid in the urine after loading dose with histamine. And the management of megaloblastic anemia due to folic acid, the management involved oral or parenteral folic acid therapy 1 to 5 milligram per day for 3 to 4 weeks, along with concomitant vitamin B12 supplementation. Miscellaneous cause of megaloblastic anemia. The congenital disorders of DNA synthesis, there is orotic aciduria, thiamine responsive megaloblastic anemia, there is a congenital dyserythropoietic anemia, and the Lex-Nyhan syndrome. It results into megaloblastic anemia. And acquired defect in a DNA synthesis, there is a liver disorders, leukemia, particularly acute myeloblastic anemia, sideroblastic anemia, and the aplastic anemia. And the drug-induced megaloblastosis, there is a purine analog, there is a 6-mercaptopurine or azathioprine or thioguanine, the drug-induced megaloblastic anemia. There is a pyrimidine analogs, there is a 5-fluorouracil and 6-azauridim, an inhibitor of nucleotide reductase, there is a cytosine, arabinoside, and 5-hydroxyurea. It leads to megaloblastic anemia. Also, folate antagonist, there is enaptarin, methotrexate, pyrimethamine and trimethoprim and triamterene, it lead to megaloblastic anemia due to folic acid deficiency. So today's key message about megaloblastic anemia, there is a vitamin B12 and folic acid deficiency are a leading cause of megaloblastic anemia. Vitamin B12 deficiency may present with pancytopenia, hemorrhagic manifestation, fever, mimicking disease like acute leukemia and aplastic anemia. Homocysteine is increased both in folate and vitamin B12 deficiency, while methyl malonic acid increase in B12 deficiency, megaloblastic anemia. Apart from anemic syndrome, patient with vitamin B12 deficiency may also present with neurological symptoms. There is a cognitive development, delayed development, and also there's a subacute combined degeneration and regression of milestones. And the development of folate deficiency with folic acid supplement should be initiated after ruling out concomitant vitamin B12 deficiency, as it increases the risk of neurological and neuropsychiatric disorders. Hypokalemia and iron deficiency can occur during treatment of severe megaloblastic anemia. Thank you.
Thank you, sir, for your wonderful presentation. You can stop sharing the screen, sir, if you want to.
Okay.
And we have few questions from our audiences, which
Okay.
we can take up now if you are ready. So, sir, the first question from our audience, which we have received, is what are possible complications of megaloblastic anemia in a child?
In megaloblastic anemia in children, mostly there is a cognitive impact on a cognitive development of the child. So there is a delayed development.
Thank you, sir. The next question from our audience is, what are the role of vitamin B12 and folate in the pathogenesis of megaloblastic anemia in children?
Basically, this folic acid and vitamin B12 important in case of DNA synthesis, RNA synthesis, protein synthesis, as well as certain cellular processes. So if there is a deficiency of folic acid and vitamin B12, so there is a defect in DNA synthesis, RNA synthesis, all cellular processes, and it leads to anemia and the impact on the development.
Thank you, sir. Next question from our audience is, what is the role of bone marrow aspiration in the diagnosis of megaloblastic anemia in children?
So rule out this megaloblastic anemia due to vitamin B12. When you see the peripheral smear, so in peripheral sees a megaloovelocyte, there's a macrocytes. Second, and there is a also pancytopenia. Anemia is there, leukopenia is there. So there's a pancytopenia. So sometime it also you think about this acute lymphocytic leukemia. So when you do bone marrow aspiration for this vitamin B12 deficient megaloblastic anemia, it is bone marrow is a hypercellular. So there's a megaloblastic hyperplasia in bone marrow in case of megaloblastic anemia due to vitamin B12. Hypercellular bone marrow and megaloblastic hyperplasia.
Thank you, sir. The next question is, what is the anemia level in the children?
What is anemia?
Level in the children.
So there is a pallor, the presentation is pallor is there, failure to thrive, malnutrition, malabsorption. In case of this megaloblastic anemia, there is knuckle pigmentation. Also, there is a impact on delayed cognitive development. So pallor, main feature is pallor and irritable child is.
Next is, sir, what is the CBC test for a child?
Complete blood count.
Okay. Thank you, sir.
Yes, skilling test.
CBC test for a child. The question is,
Complete blood count. So do
Yes.
peripheral smear. If you do peripheral smear, then there is a megaloblast is there. So there's a macroovelocytes in the peripheral smear. And second important feature, these neutrophil, they are hypersegmented. When there's a neutrophil hypersegmented, there is a more than 5 lobes in the neutrophil. And second, there's a macroovelocytes in peripheral smear is the diagnostic feature of megaloblastic anemia.
Thank you, sir. Next question is, which two vitamins deficiency can cause megaloblastic anemia?
First, it is a folic acid as a B9 deficiency. And second, there is due to vitamin B12 deficiency, B12 and B9.
Thank you, sir. That's all we have from our audience, sir. With your permission, I would like to conclude the session. Any concluding remarks from you, sir?
So whenever you think of megaloblastic anemia, because vitamin B12 deficiency, most common in vegetarian person, because the main source of this vitamin B12 in a non-veg, so main source is the liver and eggs. So it is most commonly affected is a vegetarian. While so when you suspect this megaloblastic anemia, so do peripheral smear and see two things. One, there is the macroovelocytes in the peripheral smear and hyper segmented neutrophil on peripheral smear. And most common incidents due to vitamin B12 and folic acid megaloblastic anemia, the prevalence rate is 65%.
Thank you, sir. Thank you for joining with us today. It was a wonderful